The next speaker is going to be Brian Hyslop, who's an associate professor in radiology at UNC, is going to give an update on MR applications.
I'm going to be speaking today on applications of MRI in oncology. And after a brief comparison between CT and MR, I'm going to give several examples of applications of MRI for anatomic imaging, which we are accustomed to, but also molecular imaging using both endogenous and exogenous contrast agents and MR spectroscopy. By way of historical perspective, I just want to remind people that much of magnetic resonance, pulsed spectroscopy, diffusional measurements with magnetic resonance, these were all developed decades before MRI itself was invented. The latter occurred in the early 70s. With CT, the image contrast is based on X-ray absorption. We commonly give intravenous contrast and rely on contrast kinetics. Because we're dealing with ionizing radiation, we are limited when dealing with people as to how many times we can scan to map out contrast dynamics. With MRI, we do not have those limitations, and we have a lot of different levers we can use to develop image contrast. There's intrinsic parameters based on relaxation times. There's resonance frequencies, which forms the basis for image-guided or MR spectroscopy and imaging combined. And again, there is contrast mechanisms based on diffusion or perfusion, as well as contrast agents that we administer as physicians. One big advantage of CT is the time it takes to acquire an image, which is in seconds as opposed to MR, which more commonly is several minutes for a complete study. Ionizing radiation, of course, present in CT. Absolute quantification is more readily obtained with CT because the Hounsfield unit is normalized to that of water, whereas with MRI image intensities, they're typically more subjective. You can have ratios of pre and post contrast imaging for relative enhancement, but there isn't an absolute scale in the same way there is with CT. Flow quantification can be done with MR without contrast. Tissue characterization is superior with MR. Allergic reactions are minor incidents in both imaging modalities, but a little greater with iodinated contrast than CT. For patients with underlying renal dysfunction, CT iodinated contrast may be nephrotoxic. With MRI, with many of the gadolinium-based contrast agents, there can be an increased risk of NSF. There have been essentially no reported cases of NSF since about 2008 with the advent of more stringent guidelines for gadolinium-based contrast administration. I'm going to show a few cases for breast MRI, courtesy of Dr. Sherry Kuzmiak, who's the director of the breast imaging program here. This first case is oblique and CC views demonstrating dense breast parenchyma, very difficult to detect an underlying tumor. And here I'm showing a subtracted image. By that I mean we take a post-contrast image, subtract pre-contrast data, and all of that breast parenchyma that was obscuring visualization, but it does not enhance sufficiently, so we can focus on that spiculated mass that we're seeing. And one of the newer things in MRI is quantitative evaluation of contrast enhancement using these color maps and the dynamic curve as a function of time that we're seeing in the upper right corner, demonstrating rapid uptake of contrast and slow washout, which is characteristic for breast cancer. There are a series of cases that I could go through. I'm going to skip a few of them in the interest of time. Focus on this case, which shows two masses, one in the right breast with axillary adenopathy in the right axilla, and there's a smaller lesion in the left breast. And those are the contrast dynamics curves below. Thank you. And those, this in the lower left corresponds to the tumor in the right breast. We can see the rapid uptake of contrast and slow washout. The fibroadenoma in the left breast had slower uptake of contrast and continued enhancement with delayed imaging. Subsequent response to neoadjuvant therapy was remarkable, as one can see by the image in the upper right. We commonly think of ultrasound and CT for interventional procedures, but MR can be used for interventional procedures and is commonly used in breast imaging for interventional procedures. This is the coil. Patient is in a prone position, and biopsies may be done from a lateral approach. This is an example of a core biopsy device to provide MR guidance is placed along the lateral aspect of the breast. And this is a single image showing the tract from a needle where one can check the position of the biopsy relative to the mass following administration of contrast. We're going to move on to MR spectroscopy. Obviously, in imaging, we focus on proton spectroscopy, although other techniques such as phosphorus spectroscopy exist. MR spectroscopy has a limited availability as compared to imaging in general, but there are applications in neuro, breast, and prostate. And I'll be showing examples from prostate MR. Prostate MR, we focus on T2-weighted or fluid-sensitive imaging for anatomic imaging. We can use MR spectroscopy, and we're going to look at the spectroscopic signature of prostate cancer. And also there will be a couple images taking a look at contrast dynamics and the contribution of diffusion. These two images, that image on the left was obtained using a spine array coil. The second image shows an endorectal coil placed into the rectum so that the coils are in closer proximity to the prostate gland that allow for improved image resolution. However, both techniques can be used for prostate MR and MR spectroscopy. This is two axial images of the prostate high-resolution images, and these lines overlying the two images of the prostate gland correspond to spectra that are obtained on a voxel by voxel basis. So we're obtaining proton MR spectroscopy as a function of position within the prostate gland. So how does this help us? Here we'll look at this patient with a suspicious region, this hypointense in the lower right posterior aspect in the peripheral zone. There's an arrow in the image in the upper right corner. And then we're looking at two sets of spectra, one overlying that region suspicious for cancer, and then the other in a normal zone in the left side. And as we see here, we're looking at two spectral peaks. That on the left is choline, and that on the right is citrate peak. And in a normal prostate gland, the citrate peak is relatively high compared to the choline, but in the presence of cancer or tumor, those ratios change and the choline peaks become relatively large relative to that of citrate. So we're seeing the difference in spectroscopic signature there in comparing the abnormal cancer spectroscopy on the lower left as compared to the more normal spectroscopic signature of prostate on the lower right. Exogenous contrast agents, we are accustomed to using gadolinium-based agents in clinical imaging. Another class of agents is SPIO, or superparamagnetic iron oxide particles, essentially rust. But if you take rust and you can reproducibly make it in tens of nanometers to hundreds of nanometers, it can be useful. It can preferentially deposit in the liver or spleen or in lymph nodes. This is an example of its clinical application in a patient with prostate. So we have a 3D volume rendered image of vasculature, prostate gland, and we're going to focus our attention on these two small normal-sized nodes. One is red and one is green, and these are going to correspond to a benign and cancer-laden node. So here we're looking at a pre-contrast image here, both are comparable in size and both appear similar pre-contrast. Following the administration of an SPIO particles, the contrast is taken up. These iron oxide or rust particles are taken up by a normal lymph node, and so they appear dark on post-contrast imaging, whereas nodes that contain tumor do not take up the iron oxide particle, and as a consequence remain hyperintense. So this is a clinical example of the use of SPIO particles. However, experimentally, they're very useful because many entities, antibodies can be labeled. So these particles can be labeled with CCK, secretin. There have been reports using VEGF. Alternatively, they can be injected into cells, and using MR microscopy, the migration of those cells can be tracked over time. I also wanted to touch briefly on diffusion-weighted imaging. The MR experiment, as shown before the invention of MRI, MR could be used to measure diffusion, and that can be applied to aid in either lesion identification or the assessment of treatment response following chemotherapy. So this again is an example of a spatial image of prostate with a small mass, somewhat difficult to see because of regional artifact, but there's a mass here. This is called an ADC map, essentially a measure of the diffusion coefficients. There's a region of restricted diffusion here corresponding to this lesion. This is a assessment of quantitative contrast dynamics, where one takes into account information such as the speed of wash-in, the rate of wash-out of contrast to identify lesions that are suspicious for tumor. This is the same patient, same color-coded map, diffusion-weighted imaging, and here we're seeing the contrast dynamics, the rapid wash-in and wash-out characteristic of prostate cancer. One can identify regions or ROIs in this area and see where they lie in this joint histogram that looks at contrast uptake and extracellular volume associated with the lesion. Of course, all imaging essentially is computer-aided since the early 70s, but what I meant by this was computer-aided diagnosis, segmentation algorithms that can be applied, as well as image-guided therapy that can be used to guide surgical ablation treatment, as well as assess response to treatment based on those contrast dynamics curves that I showed on earlier slides. This is a very rough segmentation of the hepatic vasculature, showing the portal vascular system and hepatic venous system that can be extracted from images. Image fusion obviously is commonly done and will be touched on more in the next talk. Liver imaging, there are many applications. One is for screening in the cirrhotic patient, characterization of liver lesions, as well as response to ablation or chemotherapy. I'm going to show just two final cases here. One was an elderly woman with hematuria and a bladder mass, and incidentally noted was this mass in the right lobe of the liver with intrinsic edema on pre-contrast images, hypervascular with washout on delayed post-contrast imaging, as well as the primary mass in the right kidney. We see this heterogeneously enhancing mass in the right kidney compared to a more normal appearing left kidney. And she turned out to have both a transitional cell carcinoma as well as a well-differentiated HCC. But in contrast, in the second patient, there was a liver mass seen on ultrasound in a young woman, and there were two lesions seen, one of which is pedunculated. They were hyperintense on fluid-sensitive imaging. And I'll make one point here, which is that it used to be that in comparing CT and MR, one would extol the virtues of multiplanar imaging in MR, and because one was confined to axial images on CT. That's not really the case anymore. The image resolution and the slice thickness is small enough on CT that one can make use of multiplanar reconstructions. Secondly, the pre-contrast imaging appearance coupled with the characteristic enhancement pattern show this to be a pedunculated hemangioma rather than malignant tumor. I wanted to show at least one benign lesion in the oncology meeting, and so this was my opportunity. So to summarize, I wanted to I've shown many aspects of structural imaging, the use of MR in biopsy, but in the future of MR, areas of active research include diffusion-weighted imaging and/or quantitative contrast dynamics, and their role in characterizing particularly early response to treatment before the size of tumors actually changes, as well as targeted contrast agents. Thank you.